Good morning. Thank you for joining us today. I'm Paul Perlman, a program director and the lead for global health technology at the NCI Center for Global Health. In 2021, in commemoration of the CGH 10th anniversary, we launched the NCI Global Cancer Research and Control Seminar Series. In this series, we feature talks by researchers and cancer control experts working in global oncology and provide opportunities for discussion and collaboration around impactful and innovative work that addresses cancer morbidity and mortality worldwide. In today's session, I'm very happy to welcome Dr. Rebecca Richards-Kortum. Dr. Richards-Kortum is the Rice University Malcolm Gillis University Professor of Bioengineering, the Director of Rice 360 Institute for Global Health, and serves as a special advisor to the Provost on health-related research and educational initiatives. Her research has been instrumental in improving early detection of cancers and other diseases, especially in low-resource settings. She's currently working with colleagues and undergraduate students to develop a nursery of the future to provide technologies necessary to reduce neonatal death in sub-Saharan Africa to rates equivalent to the United States. Rebecca's research has led to the development of 40 patents. She is the author of the textbook Biomedical Engineering for Global Health, more than 230 refereed research papers, and 11 book chapters. Her teaching programs, research and collaborations have been supported by grants from the National Cancer Institute, National Institutes of Health, National Science Foundation, the U.S. Department of Defense, the Howard Hughes Medical Institute, the Bill and Melinda Gates Foundation, the Whitaker Foundation, and the Virginia and L.E. Simmons Family Foundation. In addition, Dr. Richards-Kortum is a member of numerous academic associations, including the National Academy of Sciences, the National Academy of Engineering, and the American Academy of Arts and Sciences. As a member of both the National Academy of Sciences and the National Academy of Engineering, she has the rare distinction of dual membership in the National Academies. In 2016, the American Institute for Medical and Biomedical Engineering presented its highest honor, the Pierre Galetti Award, to Dr. Richards-Kortum. In 2008, she was named a Howard Hughes Medical Institute professor and subsequently received a grant for the undergraduate global health program at Rice. This program won the Science Prize for Inquiry-Based Instruction from Science Magazine and the Lemelson MIT Award for Global Innovation. I'll add on a personal note that Rebecca was a PI on one of the first grants awarded by the Center for Global Health, becoming likewise an active member in the first cohort of the NCI Affordable Cancer Technologies Program investigators. As such, I've personally benefited immensely from her expertise and contributions to that program. Before turning things over to Dr. Richards-Kortum for her presentation today, I'll go over a few logistics. Please note that today's presentation is being recorded and will be available on our website at cancer.gov/globalhealth. You can find information about future presentations on our site and by following us on Twitter at NCI Global Health. Questions will be addressed during the designated Q&A time immediately following the presentation. During that time, you may either use the raise hand feature found under reactions and wait to be called on, or type your question in the chat box. If called on, please unmute yourself and ask your question. We'll now begin our presentation. Welcome, Rebecca.
It's really such a pleasure to have the opportunity to join you all today and share the work that our team is doing to develop technologies to improve early cancer detection in low resource settings. And what I wanted to do in my talk today is really just think about what are the challenges that our team has encountered as we have worked along the spectrum from idea all the way to field evaluation, and what are the lessons that we have learned and hopefully are useful and can be the point of some interesting discussion in the Q&A today. And so what I wanted to do was actually to start by acknowledging a lot of really important people without whom today's presentation would not be possible. First, the team at Rice University, particularly the work of Dr. Chelsea Smith and Jackson Kuhl, David Brennis, Brady Hunt, and Sonia Para. I will feature a lot of work that they did as part of their Ph.D. studies. Second, the really wonderful collaborative team at the MD Anderson Cancer Center, led by Kathleen Schmaler, Ellen Baker, and Mila Salcido. They are just fantastic collaborators without whom the work that I will share would not have been possible. Our collaborators at the NCI, Dr. Phil Castle, at Baylor College of Medicine, Jane Montealegre, and Michael Schurer. At Basic Health International in El Salvador, Mauricio Mazza, when he was there, and at the Barretos Cancer Hospital in Barretos, Brazil, and also in Mozambique at Maputo Central Hospital, Dr. Ceciltina Lorenzoni. And then finally, I'll share a little bit of work at the end in collaboration with Malawi Polytechnic and the team led by Teresa Makandawira. And so, I'm going to focus a lot of what I share today on cervical cancer, but we are doing similar studies for a lot of different epithelial cancers where early detection is really important, impactful, but not happening in too many low resource settings. So the kinds of things that I'll describe today with cervical cancer, we have similar studies underway with oral cancer, with bladder cancer, with esophageal cancer. I think these approaches can be used for many different types of epithelial cancer. And what is unfortunately true for many of these epithelial cancers is that when you look at the global burden of disease, as you see in the upper left of this slide, you see that the global burden of disease is concentrated in low income and underserved regions of the world and within countries. If you look at the lower left, you can see that within my own state of Texas, in the Rio Grande Valley, those 4 counties at the southern tip of the state, we have 55% higher rates of cervical cancer. And that is attributed to a lack of screening in that region. Fewer than 10% of eligible women who are uninsured are actually receiving screening. In low resource settings, this is a challenge of a lack of financial resources, a lack of healthcare infrastructure, and also a lack of trained human resources. The map on the right side of the slide shows the number of people per pathologist in different African countries. And you can see in the United States or the United Kingdom, for reference, there's roughly 1 pathologist for every 15 to 20,000 people. In a lot of African countries, that ratio is something like 1 to 1 million or 1 to 5 million. And so as technology developers, we need to think about this context of lack of human resources, lack of healthcare infrastructure, and lack of healthcare spending. When we think about cervical cancer, and there we go. And when we think about cervical cancer progression, again, the same type of progression from pre-cancer to cancer is a common feature of a lot of types of epithelial cancer. The vast majority of cervical cancers are caused by infection with the human papilloma virus. And when HPV DNA becomes integrated into the host genome, you get the expression of the viral oncoproteins E6 and E7. And these allow for the progression of dysplasia to go through low grade to high grade dysplasia, and in some cases, the development of invasive cancer. And so in focusing on screening, we have this opportunity to identify precancerous lesions and intervene by excising tissue and preventing the development of cancer. We also have primary strategies with vaccination, HPV vaccination, but again, the challenges associated with scale-up of HPV vaccination are similar to the challenges of scale-up of good screening technologies. There's a bit of a lag in advancing my slides. Sorry. But let's think about what works in high resource settings. So in high resource settings, what is recommended is screening. And depending, you can screen with HPV DNA testing. For example, every 5 years, you can see the Sepia Gene Expert test is one example of a good HPV DNA test, or cytology, the pap smear, every 3 years. Women who screen positive then are followed up for a confirmatory diagnosis. And typically that's done with a combination of colposcopy, biopsy, and histopathology. And then women who have biopsy-proven high-grade disease are typically treated, and there are a number of treatments that can be performed in an outpatient setting, including cryoablation, thermal ablation, or the loop electrosurgical excision procedure. All of these together are very effective, and when combined with primary prevention of the HPV vaccine, we really have so many tools at our disposal to eliminate cervical cancer. They require money, they require infrastructure, and they require trained personnel that simply are missing in many low resource settings. And to give you a sense of that context, I have a couple of photos from some of the places where we and our colleagues have worked. And so if you think at the community level, the photo on the left was taken at a community health center in the DRC by one of our collaborators from University of North Carolina. And you can see in this laboratory setting, you've got basically a light microscope and a little hand crank centrifuge and no electricity. And really no effective supply chain for supplying reagents. And contrast that to a tertiary hospital in Ethiopia on the right. And this is a laboratory where, in particular, PEPFAR put a lot of improvements to bring laboratory infrastructure up to a level that can support automated analyzers and things like the gene expert test. So you have sort of a very wide range of types of diagnostic settings when you work in low resource settings. And so in light of that, if we look at WHO recommendations for cervical cancer prevention, the recommendations are either HPV DNA-based screening and a screen and treat approach. So you screen with the HPV DNA test women starting at the age of 30 years, and then simply treat all women who test positive. We know that this results in some rate of overtreatment, but it's judged to be an acceptable rate of overtreatment given the benefit of cancer prevention. And so sufficient resources are available, and an alternative strategy to minimize those rates of overtreatment is to implement a screen, triage, and treat program where you screen women again with HPV DNA testing, then implement a triage test to determine which of those screen positive women do need treatment, and then follow up with treatment. And so, and thinking about as engineers, as scientists, as clinicians who are collaborating together to think about how we develop approaches that are that will result in equitable detection of early cervical cancer. What I wanted to do today is really focus in on 4 themes. So the first is, can we provide molecular diagnostics for cancer screening that can be used at any clinic anywhere? The second is, can we follow that up with triage tests that allow early cancer detection in rural and under-resourced settings? And can we better job of sort of pinpointing where diagnostic biopsies should be obtained, or where areas of precancerous or neoplastic tissue should be surgically resected? And then finally, can we provide the ability to do expert pathology at any hospital anywhere? So I want to share just a little bit on each of these 4 themes. About the things that are important as an engineer in thinking about those 4 themes. About a place in the hospital where technology goes when it doesn't work anymore. This is a hospital in Blantyre, Malawi, but many hospitals in low resource settings have a similar room that often is referred to as the equipment graveyard, where devices that no longer function are taken. Often they can't be repaired because of lack of spare parts. And it's important to think about what does this mean for the design strategies that you should use. And I personally think we all should think through the lens of devices should come with warning stickers. If they're not used, they can't be helpful. And how do we think about design so that technologies can be used consistently over time? And so let me focus first on molecular diagnostics for cancer screening and share a little bit of what we've been doing to develop point of care HPV DNA testing. If we think about what is available in high resource settings, there are tests that are based on hybrid capture, the Digene hybrid capture test, or there are tests and the CARE HPV test, or there are tests that are based on PCR amplification for detection of HPV DNA. That's the Gene Expert test is a good example of that. With requiring infrastructure that is expensive, having a per test cost that can be a barrier. The most sensitive test is Gene Expert, but at $15 to $20 a test, it's expensive. We have been developing point of care tests based on the hybrid capture approach, as well as amplification of DNA. And I'd like to share just a little bit of both the accomplishments and challenges of those approaches. We started looking at hybrid capture, which basically is an ELISA-based approach to detect the presence of high-risk HPV DNA. So you take your sample, you denature it, the HPV DNA is hybridized with complementary RNA of high-risk types, and then you use an ELISA strategy to detect those RNA antibodies, detection antibodies that are functionalized to produce a chemiluminescent signal. And in the CARE HPV test, this is done basically in a 96 well plate. There have been a lot of advances in two-dimensional paper diagnostics, and our team has developed a two-dimensional paper and plastic device that can implement the hybrid capture reaction. And so you see a cellulose strip running along the right side, and then a series of glass fiber pads that contain the lyophilized reagents that are needed to sequentially deliver the reagents to perform the hybrid capture reaction. And so how is this test used? On the left in this photo, you see all of the tools that are needed to implement the test. So the sample is collected with a swab placed in a tube of a tris-based buffer. Then you would take, using an exact volume pipette, and transfer an amount of the sample to a lysis tube that contains lyophilized ACP to lyse the cells and lyophilized RNA hybrids to capture the high-risk DNA if it's present. It's heated in a heat block at 95 degrees C for 5 minutes and then placed on the sample collection pad in step 4 there. Then you rehydrate all those reagent pads, and they contain sequentially the detection antibody, and then your colorimetric reagents and wash buffer steps. You fold it closed so that those pads containing the rehydrated reagents are now in contact with your nitrocellulose strip, and you'll get sequential flow of those reagents down the test strip. So things will flow past the capture antibody, and you'll actually carry out the reaction, and you can read it out visually. There's a brown precipitate that forms at the test line. And so we evaluated and optimized this assay. Sorry, things are just not predictable with the slide advancement here. We optimized and tested things using 4 targets of increasing biological complexity. We started with perfectly complementary short HPV DNA synthetic targets and RNA probes. We then moved to full-length HPV DNA using the RNA probes from QIAGEN. We then moved to HPV positive and negative cell lines, and then finally to clinical samples. Great results with the short synthetic targets. On the left, you see results with the Digene hybrid capture assay using the same targets. On the right, you see the HPV DNA paper assay. The signal to background is plotted on the y-axis. We have decreasing concentrations of high-risk HPV DNA on the x-axis, and then very importantly, a test with low-risk HPV DNA at high concentration, because we don't want the test to be positive in that case. And so you can see we have a little bit better limit of detection with the digene hybrid capture assay, but a good limit of detection with the paper assay. We then moved to full-length DNA. Again, testing decreasing concentrations of high-risk HPV DNA with the paper assay on the left, the digene hybrid capture assay on the right, and testing the low-risk HPV DNA because we don't want false positives there. And we have similar limits of detection with the paper assay and the digene hybrid capture assay. Finally, we moved to cell lines. So we looked at an HPV positive cell line, CHA cells, an HPV 18 positive cell line, HeLa cells, and we mixed these together with an HPV negative cell line, C33A cells. So we kept in all these experiments the total number of cells constant, but we decreased the fraction of HPV positive cells. And you can see that we get clean negatives with the C33A cells. Our limit of detection is about 1 × 10⁵ CHA cells per mil and 1 × 10⁴ per ml. And we were able to test this with our lysis procedure using lyophilized reagents, and all of the reagents were lyophilized on the paper strip. And so we were really excited at this point now with all of the control samples that we wanted to test, and we moved into looking at clinical samples. And so here we tested clinical samples. These were provider collected clinical samples that were collected in El Salvador in collaboration with Dr. Matza and his team there. The gold standard here was the clinical care HPV assay, and we selected 8 HPV positive samples and 8 HPV negative samples. And these samples were tested in a lab in a high resource setting. All of the reagents were lyophilized on the strip, but it wasn't a field evaluation. We didn't try to sort the strips to a low resource setting. And you can see that we were able to get clean negatives on all of the negatives, and we had 1 false negative in this evaluation. And so next we moved to do a field assessment. So again, we lyophilized all of the reagents and we took everything to Mozambique. Now in Mozambique, our gold standard, the clinical gold standard that's being used is now Gene Expert, which is a more sensitive gold standard. And in addition to that, these are now self-collected samples. Collected samples that the concentration of cells is higher, and we could see that the samples were significantly more turbid than the samples that we had been testing from El Salvador. And you can see again, we tested 8 HPV negative samples, 8 high-risk HPV positive samples, and our results weren't as good. And prior to testing the clinical samples, we tested cell lines that we transported with us with the fully lyophilized reagents, and we got great results. Everything looked beautiful. The HPV positive cell lines were positive. The HPV negative cell lines were negative. So we were able to successfully transport the sample, but all of a sudden, we weren't getting the same sort of separation between the positives and the negatives. And to make a long story short, the secondary structure associated with cellular RNA is a problem that can drive false positives in a paper-based ELISA. It doesn't cause problems when you do this in a 96 well plate, but when you do it on a nitrocellulose platform, it can lead to false positives. And so we took a step back, and instead of working with the lyophilized reagents, we worked with liquid reagents. And we added RNase to our sample preparation strategy. And when we did that, what we found, now what we're looking at on this right graph is the signal to background for our HPV negative and positive samples before and after this RNase treatment. And you can see that our false negatives the signal from the negatives goes down. The signal from the positives goes down, but not to the same degree. And we get a little bit better separation. And so what this said to us is that it's so important that this process of optimization of the sample processing happen in field settings with the same kind of samples that you will be testing in those field samples. And so I think we're working to continue to improve that sample processing procedure to further reduce the amount of secondary structure that gives rise to the some of those false positive results. And in addition to that, we're also working to incorporate a cellular control so that if the concentration of cells is too low, that that you are aware of that in your assay. And that's something that's missing from the CARE-HPV assay, but included in the Gene Expert assay, for example. At the same time, we're also exploring assays that are based on the amplification of nucleic acids to get more sensitive results. And we've been collaborating with a company called Axon to implement an isothermal amplification assay that's based on recombinase RPA amplification. In that strategy, there is a battery-powered device that is used to provide heat at two steps in the reaction, one during the sample processing procedure and one to power the isothermal amplification. And so to implement this assay, again, you would collect the sample using a swab, transfer it to the lysis tube, incubate that lysis tube first at room temperature and then at a higher temperature in the heater, transfer the lysate to the amplification chamber that contains the lyophilized enzymes for the RPA amplification procedure, and heat that amplification chamber for 20 minutes. Finally, take the amplification chamber and twist it on to a lateral flow cartridge that's completely enclosed. And then the amplicons run down the lateral flow assay. And you can read it out again visually. You can see the control line and the two test lines in this case. And so we've evaluated this again using clinical samples that were self-collected in this case, and we compared the results to quantitative PCR. It was detecting HPV 16 and HPV that are both 16 or 18 positive, as well as a number of samples that were negative. On the y-axis, you see the test line signal from this assay. On the x-axis, you see the concentration of HPV DNA. And you can see above 3 log copies per reaction, we have really excellent results with the assay. We also have completely clean negatives. And so we need to push the limit of detection down a little bit to be to the limit of detection that is possible with PCR. And thinking about what is necessary to move molecular diagnostics forward, we really need to focus on integrated sample to answer testing systems that incorporate sample preparation. I think this is an often overlooked component of an assay that often needs significant optimization. And then thinking about how are tests like this distributed, our team in Mozambique still has so many challenges with distribution of Gene Expert, which is commercially available, and the distribution and covering the cost of this test is today still a very significant challenge. And then thinking about how the health system comes together to close the gaps between testing and between treatment. So I want to turn now to thinking about once women screen positive and you'd like to do something to confirm that positive test, what are the opportunities for low-cost technologies? And I want to share 2 technologies that I think are really exciting that come from other groups that I think really will change the future of cervical cancer screening and diagnosis. And these are digital colposcopes. The first is one developed by Mobile ODT. You can see it's based on a cell phone and it captures a digital image of the cervix. And there's been a lot of work to develop AI-based interpretation of those digital images for automated diagnosis. And then on the right, you see the pocket colposcope, which was developed by Nimi Ramanujam and her team at Duke University, also has been commercialized and FDA cleared, generates really beautiful digital images of the cervix. And we have been collaborating with Nimi and her team to think about how to combine those digital images with high resolution images. And so I want to share now a little bit of work that we have been doing. Here you see the mobile ODT colposcope in a clinic at Barretto's Cancer Hospital, together with a high resolution fiber optic microscope that can be used with the guidance of a digital colposcope to get the same kind of images of the cervix with cellular resolution that can help whether a region in the cervix is normal, as you see on the image in the lower left, contains high precancer. These little white dots are actually the nuclei of cervical epithelial cells, and you can see the increase in nuclear size, the nuclear crowding, and the nuclear pleomorphism. And you can do this in vivo with that fiber optic probe just in contact with the cervical epithelium. And with the development of microinvasive cancer, you can actually see the angiogenesis in the image on the lower middle of the screen. You see blood vessels associated with angiogenesis and that microinvasion. And so through the Affordable Cancer Technologies Program, we were supported to develop and evaluate this high resolution microscope in Brazil. And we demonstrated that you could implement this on a mobile screening van that traveled out to rural areas of Brazil. And we were able, through a combination of the mobile van and imaging at a central location at the Barretto's Cancer Hospital, to evaluate the performance of this compared to colposcopy and biopsy. And in a study of 1,500 women, what we were able to show is that compared to expert clinical impression through the colposcope, we had similar sensitivity for the detection of grade 3 CIN. Our sensitivity for both technologies was 96%, and similar specificity for CIN3 detection. Our specificity for the high resolution microendoscope was 59%, for colposcopy was 57%. And you can see the ROC curve in the graph on the upper right. We found that if we combined the high resolution microendoscope image with the results of an HPV test, we're able to shift that ROC curve to the left. The ROC curve goes up by about 0.1 to 0.9 for the ROC curve, and we gain a specificity boost of about 10% by having the results of the HPV test available at the time that the imaging is performed. And similarly, we've been able to use the same approach in mobile clinics in Texas. Here you see one in the Galveston area. And so as we think about the opportunities with imaging as a technology to improve early cancer detection for women who screen positive, we have a lot of opportunities to leverage advances in consumer grade optical equipment. It's really important to do large scale field evaluation of this, but it's also important to partner with a commercial partner that has an enduring commitment to distribution in low resource settings. And here I think the work that the Duke group has done in particular is really addressing such an important challenge here. And I think it's a model that all of us can look to. So I wanted to turn in the last 10 minutes here to thinking about two important other topics. How can we provide better guidance for diagnostic biopsy and surgical resection? And here we're thinking about the ability to combine other advances in commercial grade technology. And so here we're combining the ability to do wide field imaging, like with the digital colposcopes, high resolution imaging, and then digital light projection. And so in the system that you see here, it's being used to image the tongue. We're also, you'll see in a minute, using it to image the cervix. But what we're able to do is capture a wide field image, process it, and then project onto the tissue with a digital light projector an outline of exactly where you want to image with high resolution. So in that middle photo on the top, you see that blue outline. That's to guide the operator of the high resolution imaging system where actually to move that probe. And then we can capture images. I'll play a video here. We can capture those images at a very high frame rate. I think the video is going to encounter some struggles with my bandwidth. You can capture those images at very high frame rate as you move the probe, and you can track where the probe actually was on the tissue. And you can build up mosaics of those high resolution images, or you can track here now. We're doing the same thing in the cervix. So you see an image of the cervix. It's been stained with Lugol's iodine. And I'm going to play the video as the probe is moving across first this lesion. You can see the images update in real time. The graph on the right is scoring those images, and things that score above that red line would be high-grade precancers. And so we'll move across the first lesion. You can see the nuclei get a little bit bigger here. Now we move into an area of normal tissue, and we'll move back into now the second lesion. And you'll see the nuclei get a little bit larger here in the second lesion, but they're all scored under the threshold. And so we can, after the imaging procedure has been completed, we can display for the clinician exactly where the probe tracked. They can see that it went through that first lesion, which had a clinical impression of low-grade disease. A biopsy was taken in the place where that blue circle is, and the biopsy came back with cervicitis. In the second lesion, again, you can see where the biopsy was, and the clinical impression was a low-grade disease, and the biopsy came back just with inflammation. And so by combining all of these very affordable technologies, we're able to integrate all of this information and do spatial co-registration. And I think the same thing can be done with low-cost confocal imaging, with low-cost vascular imaging, and we can actually project right onto the tissue to help guide clinical actions like biopsy or like surgical resection. And so we need also to do large-scale field evaluations. And we have an academic industrial partnership grant where we are just carrying out a large-scale field evaluation, again, in collaboration with Barretto's Cancer Hospital in the case of the cervix. So finally, briefly, some work we're doing to try and make pathology more available at hospitals. And so if you think about the resources that are needed to do surgical pathology, when a tissue is resected, we want to examine that under a microscope. And there's a lot of infrastructure that is required to determine whether the margins of that resected tissue are negative or positive. And when we think about all of the infrastructure that's needed, when the resected sample is taken out, it's sent down to the pathology lab and it's bread lobed with a scalpel or a razor blade. A pathologist would select what slices to examine. Typically for frozen section, those will get processed, sectioned into 4-micron thick slices, stained with an automated slide stainer, and then finally they get examined under the microscope. And so we've been working with a collaborator here at Rice, Ashok Viraraghavan, to do a procedure where you could stain the tissue with a topical dye and take those that have just been dipped into a topical dye and place them right on a fluorescence microscope and automatically report the margin status. Possible with conventional microscopes. With conventional microscopes, if you want to image with high resolution, you have a very narrow depth of field. And if you just cut tissue with a scalpel, the undulations in the surface profile are much greater than your depth of focus. And so you end up with blurry images. You have to serially refocus across your sample. And so that's why we spend all the time and resources to make those very thin frozen sections. What we're doing with Dr. Veeraraghavan is to introduce a phase mask into the plane of the microscope, and it coats the light field to help make the point spread function less dependent on depth. And what that allows us to do is use a neural network to reconstruct the image so that the image is in focus all across the entire sample. And so I'll show you some results next slide, but we're able to extend the depth of focus by about an order of magnitude. And so here you see this is a slice of oral tumor that's been resected. It's been dipped into a solution of fluorescent vital dyes and then just placed onto a slide on the stage of this fluorescence microscope. And you can see in the conventional images that are shown on the right side of the slide, the conventional images are in focus in some places and out of focus in a lot of places. In contrast, the deep depth of field microscope or the deep DOF microscope, the images are clear and in focus across the entire specimen. And so we're working with Dr. Veeraraghavan and our colleagues at MD Anderson to implement AI-based interpretation algorithms as well. And I think by improving our optics, we're able to eliminate a lot of the need for sample processing. With better vital dyes and staining protocols, potentially this could incorporate molecular imaging. And as I said, with deep learning, we have the potential to incorporate real-time analysis. And so just coming back to those four topics, I think we have the opportunity to improve cancer screening, to improve cancer detection, to improve biopsy and surgical guidance, and to improve the ability to do pathology. At the same time, I think it's really important to think about how do we approach equitable technology development? How do we democratize the development of these imaging tools? And how do we really demonopolize that process? We have been working with a number of African universities to do just that, to really work with faculty and resources at these universities to strengthen the ability for hands-on engineering design and connect that to clinical challenges at the partner medical schools for many of these African universities. So the photos that you see here come from the University of Malawi Polytechnic, where with support from the Lemelson Foundation, we were able to really strengthen the rapid prototyping technologies that are available, and then put together multi-country, multidisciplinary teams to develop technologies to improve neonatal care. Here you see a CPAP device developed by those teams, but also to enable the development and the scale up of technologies for COVID. They're really advancing quite slowly. So I'm waiting for the next slide to come up. But during the COVID pandemic, these design studios were able to develop face shields, for example, that were provided to healthcare workers. They were able to develop hand washing systems that were disseminated, and they were able to also develop devices for respiratory care. I just want to with one last technology that relates to early cancer detection that came out of these design studios. So there was a partnership between Malawi Polytechnic and Rice to develop something called Lucia, which stands for a low-cost universal cervical cancer instruction apparatus. And this is basically a model of the female reproductive tract that has that show aceto whitening that demonstrate all of the low grade and high grade and invasive cancer lesions that are encountered when people perform VIA, when people take samples for HPV DNA testing, when they do colposcopy. It allows them to test thermal ablation. It allows them to practice doing leaps. You can see here the system being used in Mozambique. Some of the students who developed it in Malawi were able to participate in that. And this device has been used by the MD Anderson team all throughout Texas, throughout the US, and in many different African countries to help provide training for healthcare providers that are learning how to implement cervical cancer prevention and diagnosis and treatment. So let me stop there. Thank you so much. I'm happy to take any questions that you might have.
So thank you, Rebecca, for a great presentation and for covering some of the magnificent breadth of your work. We are going to open for questions. If people are able and comfortable, we invite you to turn on your cameras so that we can see you for the Q&A portion. And as a reminder, if you have a question or comment, you can either use the raise hand feature found under reactions and wait to be called on, or type your question into the chat box. And we'll try to get to as many as we can. I am going to use the chair's prerogative and ask a question up top. I had a somewhat downstream question for you, Rebecca. We all saw throughout the pandemic the impact of globalized supply chains on diagnostics manufacturers and really access to diagnostics in general, especially as it related to nitrocellulose, swabs, reagents, various resins, and VTM. And while such challenges are unfamiliar to many in the US, this is pretty persistent in many LMICs. And I was curious to what extent you have strategies that you bring into the earliest sort of design stages of new technologies and interventions to sort of think about being resilient to issues of scarcity.
I think it's such an important question, and it's an everyday problem in low resource settings. It's not just a pandemic problem, as you noted. And I think there's sort of two competing factors that I think it's really important to think about. So one is, I think as technology developers, I think nobody wants a different set of regulatory standards for high resource settings and low resource settings. We don't want poor technologies for poor people. And I think thinking about what regulatory standards are important and appropriate, the decision that our team made for our newborn care project was really, we're requiring one of the big 5 regulatory agency approvals, and we're requiring production in an ISO 13485 environment. And I just personally think there is no substitute for that. It does require investment, it does require infrastructure, but I don't think there is a substitute for it that is appropriately safe. Means if you're going to substitute a reagent, you have to really track all of those substitutions and you have to validate all of those reagents. I think you can do some of that upfront so that you can specify, these 3 types of pad choices are validated and appropriate, or, these 3 brands are appropriate. And I think it's smart to do that. All of us learned that in the pandemic. So I think it can be done upfront, but I think it needs to be done in the right regulatory framework as well.
Thank you. I saw Ashish next. If you'd like to unmute yourself and ask your question.
Thanks, Paul. Excellent talk, Professor Rebecca. Loved it. I had a couple of questions. One was the mobile ODT solution that you showed. How cost effective it is. I just briefly looked up the website. It seems to be a for-profit company. So I was just curious, for the deployment that you had, did they have a gratis deployment because it was in a low income country? And The second question I had was, have you had any deployments in India? I'm based in India and I would love to collaborate. I was just curious, have you had any discussions or deployments in India? Thank you. Love the talk.
Yeah. So we haven't had any deployments in India for our cervical cancer project. We did some work related to oral cancer there, but not with cervical cancer. My understanding, and I don't want to speak for mobile ODT, but my understanding is that the company made a business decision several years ago to focus more on higher income settings. And there was an original commitment at the company to focus more on low resource settings, and then there was a change. And I think, you know, that is a risk of partnering with any for-profit company is, you know, at the end of the day, that they have business decisions that they have to make. I think thinking about commercializing technologies from our own side, I will say we have partnered with both nonprofit and for-profit organizations. I think when you think about prioritizing markets in low resource settings, it is a huge challenge, whether you are a for-profit or a not-for-profit, it is a huge challenge just to cover the cost of manufacturing and distribution and break even. And so I'll give you an example from our CPAP device that we developed. You know, in that case, the cost of goods for the CPAP device, it's somewhere around $800. It's sold for $900. So it's sold just to cover the cost of goods. Distribution in low resource settings, you have to plan on adding a factor of 2 to cover the cost of distribution. I wish it wasn't true, but it is true. And it got even higher in COVID because international shipping, the price of it skyrocketed. And so there's a very real tension and a very real challenge in going to get to scale. Who is going to write the check to pay for the cost of the technology and the cost of the distribution? And how do organizations that are trying to do that survive and cover their costs? It is not easy. And I think it doesn't, in my opinion, it doesn't get as much attention, but it needs to, because it's a huge problem. You can look at, you know, I think Gradient is another example of, here's a company, they make anesthesia machines for low resource settings. They have a great product, in my opinion. I have nothing to do with it. I'm an admirer of it. I think it's a great product. And I think, you know, it's another example of a company that struggles with this challenge of how do you balance, somehow you got to cover your costs, but you want to keep the price as low as possible so that people have access to it.
And a quick addendum, do you feel training is key? Because you do an initial deployment and then the day-to-day has to be carried out by your partner there. So it's very critical to do high quality training. And do you visit them often and periodically assess how well they're doing and tell them about new versions and how to improve?
I think, yeah, training is absolutely essential. And I actually think that's kind of an overlooked area for technology developers, thinking about how you can create devices that can build hands-on skills and do low dose, high frequency training is really critical. We have a collaboration in our neonatal project in Nigeria. And one of the big challenges in Nigeria right now is brain drain. Like you have so many nurses who they get trained and then they get a job in another country with a better salary and they leave. You're just constantly training and retraining and retraining because there's so much rotation on the clinical team. And so thinking about, you know, affordable tools that can help quickly build and assess competency, I think is a really, it's an underexplored niche for technology development.
Great, thanks. I see Ramila is next.
Hello. Thank you, Rebecca. It was a really excellent presentation and very informative for me. And I also, I'm Ramila from China, also focusing on the cervical cancer prevention, especially in low resource settings. And regarding to your last part, which is like slide-free pathology, I have a question. Like in China, our practice would be like that if the woman had biopsy in the preliminary hospitals and diagnosed with high-grade lesions, and they will be referred to the higher level hospitals for the treatment. And if the when they go to the higher level hospitals, and if sometimes the doctors from higher level hospitals cannot confirm their disease status, they will ask the woman to take back their preliminary pathology slides to recheck and confirm their disease status to decide the next step of treatment. So if we use the slide-free biopsies, then how can we like track back to their primary biopsy status if we have like a dilemma afterwards?
Yeah.
Thank you.
Yeah, I think that's a great question. I think the digital images would be available and could be stored and shared, but I think you do lose the ability if you want to recut the sample, for example. That's not possible with this approach. So it's an important issue that you raise. I think that that work is at a very early stage, and sort of thinking about what are all those issues and what would you need to be sure that you can enable at the follow-up stage is an important consideration.
Yeah, thank you. Thank you.
Pushpa. Pushpa, you're on mute. You're muted, Pushpa.
Okay, can you hear me now? Yeah, okay. Great to see you, Rebecca. Wonderful. Great talk. And so nice to see how far the project has come and all the new things that you've added to it. Couple of things, just to follow up on the previous question, the tissue, you said you'd have the digital images, but could the tissue be saved? Could that be frozen so that later on it could be cut or re-examined?
Yeah, for sure. You could either preserve it or freeze it.
Yeah, so at least that would be something that if somebody wanted to go back and recheck, then that would be an option. The issue of cost for manufacturing a device you were talking about, that we've had those discussions, and it's a major problem. One of the solutions I think we had, or an idea, was to have get the device manufactured in the country where it's going to be used. If you can find someone there and partner with them, then the cost decreases, right? Because you don't have a lot of cost of shipping, and as is the labor costs get lower. So of course that's always the problem, or always a consideration, if you can find somebody to do that, to collaborate with. I don't know how one goes about doing that. That the only thing that I guess would happen is you have to talk to the collaborators there on the ground, and for them to be able to connect to people, because sitting here, it's very hard to know, how to do that. Has that been, have you talked? I'm sure you've talked about it, and you tried to explore that venue too, right?
Yeah, no, absolutely. I think in India and in China, both, there are many, many opportunities for local manufacturing that meet all of the appropriate regulatory standards and quality standards that are needed. I think right now, outside of South Africa, it's really, in my opinion, not possible to do it cost effectively in an African country. It will cost you significantly more than it would cost to do it in the United States, and certainly more than it would cost to do it in India or China. And I think there are some good examples of partnerships with Indian manufacturers. So, one that I'm aware of is there's a nonprofit called DREV in the Bay Area. They developed some phototherapy lights. They worked with Phoenix Medical in India, and were able to scale up quite effectively those lights, which were made in India, but distributed all over the world, including in Africa. And so I think that's probably the most likely route for that, is that there's just not yet enough infrastructure outside of South Africa to do it cost effectively.
I unfortunately have the sad responsibility to conclude our session for today and our series for this calendar year. I want to thank you again, Dr. Richards-Kortum, for joining us. And I want to remind everyone else on this meeting to join us in the new year for an exciting lineup of additional speakers that we'll announce soon on our website at cancer.gov/global health, where you'll also find additional information not only about the upcoming sessions, but our past recorded sessions, funding opportunities, events, news, and more. And remember to follow us on Twitter at NCI Global Health. Thanks for joining us.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.